Hey guys, okay, so this is for the applying pharmacology homework assignment, and I did mine over the hyperkalemia and management. So hyperkalemia is for high potassium. So a normal potassium is going to be 3.6 to 5.2 millimoles per liter, which granted, we can't test that on the truck, but they do test that in the hospital. And I'll get to how we can kind of identify hyperkalemia on the truck. So a potassium higher than 6.0 millimoles per liters is super dangerous, okay? The causes can be acute kidney failure, chronic kidney disease, a person on beta blockers for extended periods of time, dehydration, type 1 diabetes, angiotensin 2 receptor blockers, burns, things like that. So your signs are going to be muscle fatigue, weakness, paralysis, arrhythmias, and nausea. Okay. Now, like I said, you can recognize this sometimes on the truck. It's not a definitive test, but this is one we actually have had a couple of cases of this recently on the service where I work at. And the biggest way that they notice it is first you'll see, depending on where they are in their hyperkalemic state, right? So they can have super peaked T waves, and in the algorithm I share, I will show you kind of what that looks like. But so they're going to start out with peaked T waves. So they're super pointy and tented. They're going to have widened QRSs kind of in the next step, still with that peaked T wave, and then indiscernible or super small P waves, or they're just kind of completely gone. So it's like that T wave peaks, and then it's like somebody grabs out to the left of that and starts pulling and stretching that out. So the P disappears and the QRS widens. Is kind of how it looks to me, as far as like the stretching it out, right? So you can't strictly rely on the ECG changes, like I said. I mean, I've seen it happen, but it's not a super definitive test. Really, you have to do the blood tests, right? So management of hyperkalemia, there's a couple of different ones I'll go over with you, but a list of a few was calcium. They give 10 mils IV over 2 to 3 minutes, and it has a 1 to 3 minute onset time. They do insulin. It's a short acting fix for the problem. They do 10 units of IV, 20 minute onset. Albuterol, which is a fun one, and I'll kind of go over how that was different. 10 to 20 milligrams inhaled, onset's about 30 minutes. Furosemide, 40 to 80 milligrams IV, its onset's about 15 minutes. And sodium bicarb. And they do 1 mil per kilo in an 8.4 solution, and it can potentially take hours to work. And I'll kind of explain that. So bicarb is controversial and not really the first recommended line of defense for hyperkalemia. Now, most of the times I've seen hyperkalemia on the truck, they've used bicarb because we don't carry the calcium gluconate on the truck, right? And the calcium gluconate is going to be the highest recommended one, because it's going to be the fastest acting and lots of other benefits, okay? So bicarb is controversial, like I said. The calcium gluconate, what it does is it stabilizes the membrane potential, and it antagonizes the effects on the threshold potential and the speed of impulses, right? So it's a propagation at the cellular level, okay? Albuterol stimulates the sodium, potassium, and ATPase, which results in intracellular shift of that potassium, right? But it doesn't really work if their hyperkalemia is coming from chronic use of beta blockers. So if your patient is on beta blockers, the albuterol treatment may not work. I'm not saying it won't, but it may not. The bicarb, so like I said, we typically use the bicarb, and we just use the premix that we have, the sodium bicarb premix deals. Last time they tried to use that on the truck, they actually called in for the hyperkalemia to medical control, and medical control, that's where I first heard of the calcium gluconate. They wanted us to do that. We don't have that on the truck. So then we moved to the albuterol, which did at least help some. They ended up doing the calcium gluconate whenever we got to the hospital. I think that's pretty much it as far as what I can give you on it. It can be very, very bad. It's definitely something we have to treat and get them to the hospital for further treatment because, like I said, it could have come from many different things, underlying diseases, or it could have come from something acute. So our biggest thing is to try to counteract that if we can, or to at least slow it down, get them to a higher level of care. That's it.